Good evening and good morning to some of you. First of all, Happy New Year to all of you. And welcome to our first webinar in 2024. And today we are very honored and glad to have Associate Professor Pilo Hesis join us as speakers. Dr. Pilo is a faculty member at King's College and UCLA. He was actually a medical doctor before he pursued a PhD in genetic medicine at Oxford. Over the years, Pilo has published more than 200 papers, and many of them are in high-impact journals such as Nature Genetics and Nature Medicines. And in the webinar today, he's going to share with us his journey in using big data analytics to facilitate precision medicines. Pilo, the stage is all yours.
Thank you so much, Professor Chang. Again, like a big thank you to the organizers for giving me the privilege to participate in your seminar series. It's so great to actually see a lot of sort of familiar faces on the screen at least. And it's always like an honor to interact with our colleagues and friends in Singapore. I'm not quite sure if I can actually share the slides or you can actually see my slides right now.
Yes, you can share the slide.
Not sharing it before. Great. So it's hopefully visible in your screens as well. Yeah.
Yes, we can see it.
Great. So again, like, good evening to everybody in Singapore, or a great day, like wherever you are in the world following us. Today's topic is going to be about how genomics and other omics might actually be shaping the future of personalized eye care in the world. A very ambitious title. But like everything ambitious, it started with one small step. And the precision medicine had this advent with the Human Genome Project that was launched, if you might just remember, in the early 21st century, just at the turn of the century. This is what Dr. Francis Collins had to say in the inaugural event in June 2000 about the Human Genome Project. Genome science will have a real impact on all our lives. It will revolutionize the diagnosis, prevention, and treatment of most, if not all, human diseases. In coming years, doctors increasingly will be able to cure diseases by attacking their genetic roots, and it is now conceivable that our children's children will know the term cancer only as a constellation of stars. There are many great thoughts in these sentences, but the three keywords I wanted to draw your attention to is our diagnosis, prevention, and treatment. Those were the early promises of the precision medicine movement, and those are the three keywords around which my talk today will revolve. Part of my interest today will be to actually show us like how precision medicine has kept its promise in terms of improved diagnosis, prevention, and treatment for common diseases. The precision or personalized medicine movement was facilitated by the availability of big data in genomics. Genomics is a major data source. Right now, the genomics data volume is around 1 exabyte, which is 10 to the power of 18 individual bytes. And it is expected to turn to at about 40 exabytes by the end of this decade. In the process, we will have to change our metaphors for enormous from astronomical to genomical, because genomics is about to overtake astronomy as single biggest source of data in the world. As I just mentioned, it will be at around 40 exabytes by the turn of this decade. But by 2025, it is actually expected to produce more data than astronomy and social media. This huge explosion in data availability has been facilitated by many factors. One of them is the availability of ever bigger national health biobanks. It all started with the Icelandic biobank and the Estonian biobanks, so two countries in Northern Europe. And it was a major step change with the availability of the UK biobank and the most recent addition of the large US-based cohort, such as all of us at the Million Veterans Program. There is also a number of direct-to-consumer companies, the 23andMe being the best known of them, that is making a lot of data available, and they have huge analytical power contributing to the genomic data availability. On top of this, we have a better ethnic representation. We have made sure that we have like a proper like ethnic representation through the availability of biobank data from Biobank Japan, China Kadoorie, Korean and Taiwanese biobanks. And of course, we're producing more than ever matching health data in the shape of electronic health records, directly measured health outcomes, as well as wearable and digital biomarkers. As a result, the genome-wide association studies have been a huge publication success. In the first years, their number was growing exponentially. Right now, it's just showing a more linear growth, as you might see in this graph, and it doesn't show any sign of abatement. As a result, more variants than ever before have been associated with disease or phenotypic traits, and our predictive capabilities are improving as a result. So this takes us to the first keyword that I just wanted to focus about, our ability to predict eye diseases. As I just mentioned, this stems directly from our ability to identify loci or variations in our DNA, in our sort of like cell nuclei that have been associated with different diseases or phenotypes. I've been involved in a number of these studies, but I just wanted to bring like 3 examples from my own work on 3 very well known and very prevalent eye conditions. Like the first one is myopia. It's the 7th most common condition in the world, and is the 2nd cause of visual impairment globally. Our genome-wide association studies helped explain around 18 to 19% of the overall genetic heritability. Primary open-angle glaucoma and its most common and most important risk factor, intraocular pressure, can cause irreversible blindness in the world, and it's leading cause. Primary open-angle glaucoma is the primary cause of irreversible blindness in the world. RGLOS helped explain around 9 to 10% of the disease heritability. Keratoconus is the most common of the rare diseases, or the rarest of the common diseases. It is still the most common reason for having a corneal transplant. It's a leading cause of refractive surgery failure, and RGLOS helped identify around 40 different genes associated with that, explaining 12 to 13% of the overall genetic heritability. So these studies were conducted in massive sort of data sets, and as a result, we have our genetic findings had quite a good like robustness and solidity, and therefore they will just translate to a reliable risk prediction modeling. Here I'm just like now showing the results of the 3 predicted models for the three conditions. So the one on the left is our predicted results for primary open-angle glaucoma. In the middle is keratoconus, and on the right is myopia, using 3 definitions of all glaucoma, all myopia. Myopia defined as worse than -3 diopter, and myopia worse than -5 diopter. So you have like the C3 curves. The area under the curve, for those of you who are not very familiar with the subject, is a measure of like how good and reliable those predictive models are. An area under the curve of 50%, pretty much as a toss of a coin, is completely random results, and an area under the curve of around 100, if possible, would be like the maximum we can ever attain, and results that are fully predictive and 100% reliable. We see that our predictive abilities for these 3 eye disorders are still in the middle of the range, so they just revolve around 75% range. So there is still some way to go. Normally, we are just satisfied, or we start getting satisfied when our prediction models achieve areas under the curve of around 80 to 90%, or 0.8, 0.9. Still, the performance of this disease prediction models are quite encouraging, given that they were the first serious attempts in that direction. Not only are our predictive risk scores predictive in the original population in which they were designed, in population of European origin, but they are also performing well in the face of population diversity. Here is just a result that we have of a work that we have conducted in collaboration, or led actually by our collaborators in Singapore, Xiangmei Sa and her group. For this purpose, we have been repurposing the European Genetic Association information and try to make it pertinent to other non-European ethnic groups. In this particular occasion, we've been focusing on the 3 main ethnic components of the contemporary Singaporean populations: Chinese, Indian, and Malay. Those models have been performing reasonably well, with areas under the curve that are not necessarily inferior to the areas under the curve that we have been seeing in the European populations. We achieve this by modeling the different linkage equilibrium that is seen in different populations and conditioning the results we have obtained in Europeans through observation of linkage equilibrium in the Singaporean populations. Overall, we just achieved an imperfect yet a respectable performance of around 70 to 80% of area under the curve in those 3 non-European populations. Still, areas of the curve are imprecise measures of precision because they can look great on paper, but what does it mean in practice? Here, I'm showing you the results for our predictions of myopia, the Epic Norfolk, which is a region in Epic Norfolk cohort, which is a group of volunteers from one particular area in East England, and this data is not published. So here I've just used the loosened definition of myopia, which is myopia defined as worse than -1 diopter. We have seen in the previous areas on the curve that this is the most conservative and sort of the least performing of the 3 models we have for myopia. It's still, so defining myopia more aggressively, worse than -3 or worse than -5 would have probably made this prediction a little better. But in blue here for every bar, we're showing like now the percentage of the true myopic people that are polygenic risk scores blindly identified in this test population. And the rest are individuals who were not identified as myopes according to our PRS. So individuals who were, again, classified as normal. We see that the percentage of individuals who were rightly identified as myopes grows with the decile of the polygenic risk scores in the population, but they don't quite attain the true population prevalence that we see in this particular group of people. And that means that our predictive capabilities are on the right track, but they're not 100% reliable yet for myopia, and more needs to be done. However, this dependence or this relationship between our capability to predict true myopia as a function of genetic polygenic risk scores is, again, like showing signs that it's going in the right direction. It is always good at predicting extremes of myopia. So it's always better to predict how many individuals will be myopic if there are of the extreme deciles of the distribution of the genetic risk in the population. Myopia, though, is a case apart because for most diseases outside of ophthalmology, we see that the predictive capabilities are actually not that great. And these are the results that have been published by Arun Hingirani at the University College London, in which work he essentially derived all the polygenic risk scores that are available through public repositories, primarily a resource called the Polygenic Risk Score Catalog, which is open access to all. And he's showing, what he's showing in this graph here are different polygenic risk scores performances showing as box plots, because there are more than one polygenic risk score for each disease, showing on the x-axis. What these box plots are showing is how many people are truly diagnosed, like how many individuals who truly have the disease are diagnosed using polygenic risk scores, as a function of how many false positives you had for that same polygenic risk score. In other words, this is showing the balance between true positives and false negatives for any polygenic risk scores. We see that the overall performance is quite low. So we would just only be diagnosing about like not 10% in average of true positives for any disease in order to have a high, like an acceptable rate of false positive rates in the population. So again, like eye disorders and myopia in particular are kind of like outliers compared to like other diseases for which we have polygenic risk scores outside of ophthalmology. So we should feel actually quite privileged for having rather better polygenic risk scores. What is the source of that luck? First of all, it has something to do with the way that polygenic risk scores have been reported in the literature. Often there is a matter of quality of the testing data sets. There is a certain feeling that sometimes those testing data sets and results obtained with them are kind of like optimistic, and they just like yielding inflated sort of predictive matrix in those like testing populations. So they may not all polygenic risk scores might actually be as good as they claim to be. But also an important factor is that the predictive value, how good are we at predicting the true disease starting from pure polygenic risk scores, is also a function of the how good our initial genome-wide association studies were, like how much power we had in the initial studies. And also there's a field that the prediction performance alters with disease characteristics, particularly with disease prevalence. And I'm going to talk a little more about those two in a minute. First, again, the GWAS power is very important. So the more individuals we have for any genetic association analysis, the more power we have to detect loci or SNPs or polygenic variants that are truly associated with the disease, or in other words, true predictors of the disease. And that ability changes, again, with the number of populations that we have available. It is possible to model apparently like how many SNPs we have found using different sample sizes or in previous GWASs, but it's also possible to model what to expect in the future. So just bringing up here two predictions of what we can expect in the future for two diseases, spherical equivalent and intraocular pressure. And we see the same trend for both conditions. We see that the number of loci is going to increase initially exponentially and then hit a plateau for very large, millions of individuals for both spherical equivalent and intraocular pressure. And we will see that at around at a few millions, in terms of sample sizes, we will see that our ability to predict heritability, to explain the heritability of disease, or our ability to predict the disease starting from genomic markers will plateau after genome-wide association studies have incorporated a few millions of individuals in their initial GWASs. A few millions actually sounds a lot, but if you keep in mind that there are currently very large national data sets in the order of 500,000 to 1 million, this objective is very attainable and it's probably going to be attained in the next few years. So we're just expecting our abilities to improve from the dashed line, which is the current state of affairs in the GWASs today. We're just expecting that with the addition of a few million, with the addition of a very few national biobanks in the imminent future, our capabilities to predict disease are going to maximize, are going to go to their zenith. And of course, the power of the GWASs will improve as we include more individuals of non-European ethnicities, because certain alleles will be more common in ethnic minorities compared to European and vice versa. Therefore, sort of boosting power even for the same stable sample sizes included in those initial studies. The second point I just made before is that our ability to predict the disease is dependent on the disease prevalence. Here are the results of our simulations. The odds ratios shown here and in different colors are actually the odds ratio for the association between polygenic scores and the disease status for hypothetical disease. We don't have point estimates, but we have intervals as shown by these boxes because there are different scenarios, different cutoff scenarios. When you have a polygenic score, each individual among us will have a polygenic score, but what we consider at-risk polygenic scores will actually depend a little on our definitions, and it can vary from the 50th percentile to the top 5 centile. So therefore, there is a number of scenarios that we plugged into this simulation work. But the results, regardless of where we draw the top centiles, results were pretty similar, and they were showing some important trends. First, we're showing that our ability, the positive predictive value improves dramatically with the prevalence of the diseases. Apparently, if you have very rare diseases, kind of keratoconus sort of disease, at a prevalence of around 1 per 1,000, you don't really have any realistic chance of properly predicting disease or having a high positive predictive value that ideally should approach about 80% or 0.8 to be useful for clinical purposes. Here is the same sort of idea, but the lines here are just showing the median estimates from the previous graph. And on the top chart on the right, again, I'm showing the positive predictive values, and the bottom chart, I'm showing the negative predictive values for all the scenarios. And we see that the positive predictive values will actually start getting a lot better for odds ratios of, here the odds ratios shown on each line are 5, 10, 15, 20, 25, and 30. So the bottom line on the sort of positive predictive value of those models is an odds ratio of 5, and the top is an odds ratio of 30. We see again the same observation. So we have very little chance to actually make realistically good predictions for prevalences below 0.5% or 10%. But those abilities will get a lot better if the odds ratios approach 20 or 30. And when those prevalences just go above 20%. So this explains like why our predictive capabilities for myopia are a lot better than for other diseases that are just cataloged from different groups. And while we might have a chance for primary open-angle glaucoma, it will be very difficult to diagnose keratoconus, for example, or other rare diseases based on polygenic risk scores from genetic screening of the population. So it's important to stress that those simulation scenarios are calculated from the baseline scenario is actually a genetic screening using polygenic risk scores in wide populations. But because prevalence or relative prevalence or estimates of prevalence will actually differ depending on like how we just make a recruitment, we would have a hope if we had an enriched clinical samples. So again, we probably have to move our expectations for when it comes to genetic predictions from conducting polygenic risk score screening of the population to actually screening targeted clinical groups, because that would artificially inflate their prevalence and would boost our confidence on those results because of the prior information that we're plugging into these models. Targeting clinically enriched groups is therefore like a step forward in our ability, rather than predicting disease in the general population, that would allow us to prevent serious disease or complications in clinically defined groups. And that preventing was the second keyword I wanted to talk about. That was the second promise from the Human Genome Project 25 years ago. The idea is simple. These are actual numbers that we have seen from the NHS in the United Kingdom about like glaucoma screening of the population. So if you were to essentially just try to screen glaucoma through glaucoma clinics and glaucoma specialists in the UK at the age of 50, the prevalence of glaucoma at that age group would be around like just less than 1%. It would be 0.9%. And if you conducted screening in the clinic, those screenings currently are 73% sensitive and 96% specific. And if you screened everybody through a glaucoma clinic, you would have a 14% true positive and 86% false positive rates. So these rates are clearly not desirable. They're not optimal. They're a huge waste of money and resources for any healthcare system. However, if you try to combine the same sort of clinical testing with genetic data and genetic methodology, you just still have the same cohort of patients. But if you were focused on the patients who have a 10% genetic risk score, that will just boost your prevalence to 3.8% in those particularly targeted groups. If we submitted those 10% of patients who have the worst genetic risk scores in the population, the screening test in the clinic would still be 73% sensitive and 96% specific, but just because you have included genetic testing in the mix, we will just be ending up with 43% true positive and 57% false positives, which would be a much better rate. And that rate is bound to improve as our genetic predicting capabilities get better in the short term. Essentially, targeting particular patient groups has produced good results. And another way to think of this is let's focus on individuals who are at highest risk and try to predict when their disease might have been diagnosed otherwise, or who is more likely to develop the disease before others. All eye diseases are actually age-related, so that is something that is very pertinent to know, when somebody will need care and when somebody is likely to develop a full-fledged disease symptoms and would be at highest risk from disease complications. So here are the results of some of our work on PRS predicting the age of onset. So this is done using, this is prediction of a primary open-angle glaucoma diagnosis age and as a function of PRS centiles. We have split the individuals in the general population in three groups. The bottom centile, essentially people who have a very low glaucoma genetic risk. Individuals who are in that middle layer, the 1/3 middle, and individuals who are on the top 1/3 layer of high glaucoma genetic risk scores. The data for this polygenic risk scores are from Anthony Kawaja's latest and unpublished work on intraocular pressure, combined with other known genetic factors, such as genetic risk factors that affect Coulter disc ratio or other factors affecting optic disc resilience. So this work is unpublished, but it's hopefully going to see the light very soon during 2024. Again, we see that there is an enormous gap, even considered like 95% confidence intervals. And we believe that the age of POAG diagnosis, or the age in which POAG becomes manifest in the population, can be predicted even like using the current knowledge in the field. What does it mean? Instead of actually saying that somebody will definitely have glaucoma or definitely have AMD or myopia, we focus more on likelihoods of when the disease will happen. So again, using a similar concept and a similar information, but we just smoothen the curve, because otherwise in the general population, the curve would be like more edgy, but a smooth curve that is derived actually from the previous graph is shown here. What is missing in this graph here is a reference right here in between the green and red characters. You would have the 50th population risk centile. It's actually individuals who don't have a high risk of glaucoma, but who don't have any protective factors either. And we see that as you go towards the top centiles of risk scores for glaucoma, glaucoma starts appearing before others. So if you are at the 60th centile, you would tend to have glaucoma almost like 0.6 years before. If you were at the 70th centile, you would tend to have glaucoma 1.5 years before the middle range of the population distribution, and all the way up to the 99th centile. If you were unlucky to be on the 99th centile of the polygenic risk score for glaucoma, you would be more likely to develop glaucoma almost like 9 years before the average of the population. And the opposite is true as well. If you happen to be on the bottom centile for glaucoma genetic risk, you would tend to have, as a patient, you tend to have glaucoma developed 9 years before the middle range of the population. So this information is hugely helpful and can actually help prioritize patients who might just need more resource and more clinical attention than the rest of the population. A similar observation has been made in the PROGRESS study in Australia. Here we see that the visual field loss depends on the glaucoma polygenic risk scores. We see that the bottom dark line shows the individuals who have the top or the worst 5% polygenic risk score predicting glaucoma in the population. That 5% stands out. It's clearly a differentiated disease risk, and it's so well split from the intermediate PRS for glaucoma, or the individuals who have 20% bottom PRS genetic risk score for developing the disease. And again, our ability to predict the visual field defects is very much needed, and it would help prioritize certain patients who are more at risk of suffering consequences of having glaucoma. These are other results in the same vein. Here, I'm just trying to predict the age of developing macular degeneration in the population. And when I'm saying like age of developing, this is more like age of diagnosis. We tend to work on historical populations, and we try to back predict, if you want, or retroactively see like what is the association between the first year in which the individuals were diagnosed with the disease, and compare those ages of diagnosis with polygenic risk scores. This does not really reflect any step change moment in the development of the disease risk in the population. Because these results are actually based on historical data, there is a chance that our actual prediction might be even more accurate. People get diagnosed with AMD or glaucoma when they get diagnosed, so that has a lot to do with access to medical care, how careful or how attentive like the patients are. So it depends on a lot of factors that are not objective, but more like social or more human. So again, these tertile curves, like a splitting nicely as in this case here, tells us that we have a lot of possibilities to actually improve further, and we might actually see that in a real cohort of like prospective cohort of patients, we might just get better results than we're getting here. This work is actually conducted using the findings from the latest GWAS on AMD that is authored by Brian Gorman and Sudha Iyengar, that is going to be published in Nature Genetics in the next month or two. It's been accepted. Pharmacogenetics is a topic I just wanted to touch very briefly. It's important because it fits in the prevention theme. So it prevents the consequences of suboptimal dosing when we try to treat a disease. So genetic predisposition to response to pharmacological treatment can come in two shapes. First, genetic predisposition can alter treatment efficacy, or can also be the origin of adverse drug reactions. So both of them are very important to patients. There are currently hundreds of package inserts that contain FDI recommendations and on genome type awareness for many of these medications that are currently in the market. But most of those, like package inserts, concern metabolizing genes. Because of the way the medications are taken in ophthalmology, none of these genes actually is of concern to the general ophthalmologist because they are taken topically. So the body's metabolizing capabilities for certain drugs is not affecting their level as much as systemically administered medications. Still, like we see that genetic response to eye diseases and response to treatment is actually a topic and very important in ophthalmology. It is important in many different contexts. This slide here is actually showing the pharmacogenetics of response to prostaglandin agonist. And we see that the jury is pretty much in there. There have been very few really well-powered studies, but there are some hints that the polymorphism of the GMDS gene or the prostaglandin receptors might actually be involved in differential response to prostaglandin agonist treatment. But again, those findings are rather inconclusive, and they're just badly in need of larger sample sizes to be more definite in their conclusions. We know more about response to anti-VEGF treatment. There have been several meta-analyses on the subject, and now it seems to be like a convergence of opinion that polymorphisms in the ARMS2 and the CFH genes, respectively left and right, change the response to anti-VEGF treatment in these patients. Those effects are not huge, so the alterations are in the order of like 1.4 or 1.5, meaning that patients with certain polymorphisms, we have a relative risk of about like 40 or 50% higher than patients and than other patients who don't have this polymorphism and might just require slightly different, maybe more aggressive ways to treat their AMD. But those results are highly probabilistic, and it's very difficult to actually feed them into a proper decision-making process. And their interpretation is very difficult for many general ophthalmologists. What is less relative and more definite is our ability to predict response to treatment, to anti-VEGF treatment using digital biomarkers. Digital biomarkers is a topic I was planning to talk a lot about in this conversation with you, but I just noticed that you had previously so many authoritative investigators in this field, such as Piers Kieran and other colleagues from the Institute of Ophthalmology here in London. So I decided it would have probably been redundant. However, here I just wanted to share with you the results that have been published by Gallardo et al. Like a year or two ago. And these authors have actually conducted their predictions to anti-VEGF treatments using OCT parameters. So this is a machine learning exercise. And as a result of which, they saw that using a limited number of OCT parameters can accurately predict response to anti-VEGF treatment in a population. Those predictions are actually very accurate. They have an area under the curve of about 0.8%, which means that especially for AMD and not so well for the other retinal vascular diseases. But that means that those results are quite at the edge of the clinical translatability into general populations. With a few like refinements in the future, as more OCT data becomes available and is submitted to machine learning, we might just be able to cross that threshold and use machine learning classifiers in clinical practice and predicting response to treatment. The final keyword or the final sort of like promise from the precision medicine movement was our ability to improve disease treatment and our ability to actually change the way in which individual patients are treated. There is this new class of medication, or this separate class for my purposes of medication, that is coming into force recently. And this is a class of drugs that have been inspired by genomic findings. Genomic findings can mean different things. It can be like study in rare Mendelian type of disorders. And this has been a time-honored route to developing new drugs. For those of you who might just be familiar with the example, statins are like a very popular class that lowers cholesterol levels and is widely used in the general population. was a result of a genetic investigation of a rare form of hypercholesterolemia in the population. And there have been, throughout the years, even before the Human Genome Project, there have been several studies focusing on very rare linkage-based Mendelian disorder investigations in the population. With the advent of GWAS studies, as we've seen before, the number of genes that have been identified with in relation to diseases has skyrocketed, and therefore the number of personalized medicines, the percentage of FDA approvals has skyrocketed as well. So for the drugs that have been inspired by any genetic finding, whether it's of linkage or association origin, we tend to hover around like 30 to 40% in recent years in terms of like FDA approval rates. Having any source of genetic backup in the initial filing for a drug approval can tremendously improve the odds of the drug being approved or jumping from stage to stage in the clinical trials. So in this graph here to the right, I'm just showing the odds ratios of being approved conditional on having or not having a genetic evidence favoring or supporting your filing for a clinical trial. We see that the odds ratios are around 3 times higher for drugs that have a GWAS basis, and there are as far as 5 times higher for targets that have been identified through the investigation of Mendelian disorders, like rare disorders. Not only are the drugs that have been inspired by the Genome Project or by the genome findings, meaning that are just direct result of the precision medicine, sort of like in a movement, easier to approve, but they also cost cheaper. So here I am just showing some data from these data actually go all the way to 2019, so they're not very recent, but it shows that the median cost of developing a drug is in the order of $2.6 billion if the drug has been inspired from genomic findings, and it's around $3.5 billion in median for drugs that don't have any sort of genetic evidence supporting their viability. So in average, the genomic inspired or precision medicine drugs are $1 billion US dollars cheaper to develop compared to the old-fashioned traditional route of developing therapies. As a result, globally, not just in ophthalmology, the number of precision medicine projects has been sort of going like in a high. And here I'm just like showing the currently registered trials at different sort of clinical stages. So some of them are discovery, preclinical, phase 1, 2, 3 stages, and how many of them have been hitting the market. And again, these results are all the way up to like 2020. Ophthalmology is a small specialty, but ophthalmology accounts for 15% of all like stem cell clinical trials and about 10% of gene therapy clinical trials. It's not only like Mendelian diseases investigation that has led to precision medicine new class of drugs, but also like the GWAS results or genome-wide associated results have been leading to clinical trials already. Again, new drugs to age-related macular degeneration is leading the way. And this list here is just like showing the clinical trials that are being conducted at the moment and that are targeting different components of the pathway that leads to age-related macular degeneration in the population. Quite a lot of them are targeting through monoclonal antibodies or peptide inhibitors or aptamers, different steps in that process that activates the serial complement in the eye, leading ultimately to AMD. But there are other alternatives as well that are being tested from different pharma houses and investigators. There are more than 30 active research programs in ophthalmology that involve gene therapy. Again, gene therapy has been a field like mostly pioneered by ophthalmologists, and that's continuing strong. And there are so far 40 active registered clinical trials that have have been targeting retinal diseases and using gene therapy in the internationally in the whole world. However, personalized drugs have their limitations, so they are very expensive. This expense partly derives that personalized medicine is like kind of splitting the pool of patients. If before we're just like aiming at treating billions of patients suffering the disease, right now we're just like dividing the same pool, and we're just losing some of the advantages of the economies of scale. But also these drugs are new, so there's no generic alternative. So those drugs are bound to cost a little more. And it also depends on the sort of market position of the pharmaceutical companies developing these drugs. Quite a lot of them are powerful, but perhaps like not enough competition for a lot of these drugs, and therefore they dictate their conditions in the market. However, there's a generalized trend that personalized medications are actually getting more expensive. So for the same unit of the outcome, they're costing more in dollar terms. It's not very easy to quantify like the benefits in ophthalmology, but it's actually very easy to do that in cancer, because in cancer, like survival is actually a very measurable outcome. And for each year of life gained by a drug, we are spending, or globally, like up to 3 to 4 times more than we used to spend back in the 90s. So that's again like associated with the advance of personalized medicine, and the cost of personalized medications are becoming a problem that sooner or later needs to be targeted. And this has implications over inequality, and inequality can have different forms. So it can, individuals can have like uneven insurance coverage. So they may not, insurance that, or their payer may not be covering all these like personalized drugs in all countries or continents or areas. Access to personalized drugs can actually vary from region to region, as we saw here, and as we might just deduct from this graph here. The cost of personalized medicines, again, they vary from region to region, which is also like a measure of their purchasing power, but also regulatory and market rules like origin. So we always like see that the price of personalized medicine is much higher in North America compared to like equally wealthy countries like in Western Europe. And for no good reason, we actually see that in the developing world, those prices are even higher in Western Europe. So a market position seems to be like a major factor in these phenomena. Anyway, as a conclusion of this conversation, I just wanted to show you that the precision medicine has been perhaps like generally successful, but as every like real life story is a story of like both unmet and sometimes exceeded expectations. So in terms of unmet expectations, genetic screening at the population level, which was a dream at the onset of the Human Genome Project, kind of remains remote right now, and is probably going to be achievable in the midterm future only for diseases at a certain prevalence, so only for the likes of myopia and perhaps glaucoma. But it's probably going to be a lot more difficult to conduct genomic screening for rare diseases, I just mentioned. Genetic information remains probabilistic and not readily actionable. So it is very difficult to actually suggest a proper action to a general doctor or like specialist doctor based on polygenic risk score right now. We have not done enough work to actually translate those probabilities into like a firm recommendation or suggestion on what to do to these patients. And polygenic risk scores need to be combined with other sources of data. We're just delayed in doing this. We're just running behind our schedule in doing this, but combining genomic and other omics data with other information has huge potential that we have just started to explore. However, progress is still going on and it's still going strong. So personalized medicine has been around for like only 20 years, and most scientific discoveries have had longer translational journeys. So it typically takes like 30 to 40 years or more sometimes to actually just realize and materialize the full potential of sort of different technologies and novel sort of options and technologies. Apparently, the personalized medicine has held up its promise of accelerated new drug development, as we've been seeing those drugs are actually just being developed, and they're a lot cheaper and a lot faster to hit the market. Polygenic risk scores are stronger. They sort of like didn't meet the initial expectation, but they're still like stronger than a lot of classical epidemiological risk factors. So when we are sort of comparing polygenic risk scores in glaucoma, for example, or other diseases, the odds ratio of association with polygenic risk scores are stronger than, for example, those of smoking and for cardiovascular diseases. So polygenic risk scores are so strong risk factors that they cannot be ignored. They're not as good as we wanted them to be, but it's like relative because they're actually quite good and quite strong. And then the genomic research has been emphasizing the importance of the environment and how we measure the environment, how we quantify this. Just remember that diseases are around 50% heritable, 50% environmental, and again, like focusing on the genetic part has given us a chance to actually just realize that environment is truly important. And this is not just the philosophical realizations, but genomics has been enabling the holistic approaches and has forced us to think on how to use like clinical data and other omics information in one sort of like in a big overarching model. And those models are actually being developed like really fast, and they have a huge promise that we have just started to explore. But that's something that we didn't realize about 20 years ago. And time is just running out, so I think at this point I may just like thank you for joining, and thank you for all the attention. I'm just like happy to take any questions you might have.
Thank you, Peter. I think it's very comprehensive talk. Now, may I invite my colleague, Assistant Professor Tammy Zhong and Dr. Wendy Wang to join the panel discussions. And Assistant Professor Tam, as you all know, is a faculty member at NUS Ophthalmologist. And Dr. Wendy Wang is a consultant ophthalmologist at NUH Department of Ophthalmologist. So may we start with Dr. Tammy Zhong?
Sure. Thank you, Professor Ching, for the introduction, and thank you, Professor Pearl, for the wonderful talk. One of the most insightful ocular genetic talk that I have listened to. So thanks very much again. I do have some comments to share as well, and would like to hear your thoughts on this as well. I think Professor Pearl has covered a broad range of what these genetic findings can do, and all the past genetic studies as well. I think personally, I feel one of the important advancements that all these GWAS studies have enabled is the Mendelian randomization analysis as well. So imagine without all these GWAS findings, we are probably stuck with all the elucidating all the causality, and with newer and newer GWAS papers, we are able to have a better idea on the causality using Mendelian randomization analysis. So I think I personally will still credit GWAS for that. So that's number one. The second comment I have is I totally agree that on the actionable part, sometimes some papers they publish wonderful findings, 100+ loci discovered, etc. But probably eventually it depends on the disease. Is disease specific? Say for example, AMD progression. Do we really need to do genetic testing to predict progression, or sometimes based on OCT feature, it's a lot more predictive because it's phenotypically speaking, it's an obvious feature. And whereas versus maybe other conditions, it's not so obvious on images, etc. Maybe for those diseases, they will benefit more from genetic testing. So I think it's a matter of finding use cases, and it's a journey that we are all on at the moment. Yeah, thank you. We'd like to hear your thoughts. Thank you.
If I just sort of respond to that, I fully agree. Sometimes polygenic risk scores might actually get better, and they will get better, but sometimes seeing the reality is actually easier. Again, like just monitoring progression of eye diseases sometimes can be very easy, sometimes as easy as like having a fundus check or like an OCT. However, that implies perfect and timely access to like specialist care. Clearly, like OCTs are going to be better because they are like the golden standard we use just right now to actually evaluate how well the polygenic risk scores are performing. But I see like developments in the polygenic risk scores domain that are going to go beyond ophthalmology. I see a future in which like all adults or like old babies might actually have their own personalized or genetic data. And every individual will actually be able to calculate the polygenic risk scores, not just for eye conditions, but for any other condition as well. So that means that before too long now, individuals will actually have a better idea whether they're more likely to have that crucial first visit to see an ophthalmologist because their polygenic risk score is higher or the polygenic risk score is lower. So that might actually be a benefit. It's not quite ad hoc genetic screening of the population for one disease, but the costs are going to be perhaps like worth it because it's going to be done for like all diseases we know about. And then again, it's also a matter of prioritization. I mean, in a clinic, like every specialist doctor is very busy, or like even family doctors are very busy. So it might actually be a matter of prioritizing resources. So it may be that a patient with a very high polygenic risk score can wait less in a waiting list compared to somebody who's at the bottom of polygenic risk score priority. So that might actually help a doctor come up with a decision. It's probably going to be a second line of evidence, so it's not going to be like a deal breaker, but it might be a good addition to the arsenal the doctors are currently using.
So actually, I mean, what you comment is also relevant to one of question brought up by the participant. When do you think PRS will be used in the clinic? Peter, you have to.
I was muted. Yeah. So in one form or another, it's probably going to be like in the next 5 to 10 years. It is a wild bet. Again, predicting the future is nobody's particular strength, but it is getting there. In my view, it's a matter of having a little more powered genome-wide association studies, and that is coming because the data are just becoming available. But it's also a matter of redimensioning our expectations. So again, initially we're just thinking that we'd just be diagnosing people at birth. This is not going to happen. But having some sort of usage for polygenic risk scores that is additional to the current information that is currently used by attending doctors might be hitting the hospitals and the clinics in the next 5 to 10 years. I just wanted to add one thing to this very briefly. The genomic information polygenic risk scores are actually coming coming bedside in the shape of pharmacogenetics. For example, there is a number of hospitals in the world. I'm familiar with 2 of them in the United States who are using the polygenic risk scores to actually calculate response to therapy. I was involved with polygenic risk scores and pharmacogenetics project at the UCSF hospitals in California. And this is actually a routine part of the decision-making process. It is sort of incorporated in their computers, and it's part of the decision being made by doctors and pharmacists there.
Okay, great. Thank you. So maybe we can also invite Wendy to ask one question, and after that we can go through the participants' questions.
Thanks, Prof. So I think coming from a clinician's point of view, I think one of the areas that perhaps medical schools will need to catch up with is really training doctors as to how we're going to make use of this information and talk to patients. Because I've had a patient come in before, and I think her grandmother is blind from AMD, and she was distraught, although she's in her 40s and her macula looks completely healthy. But I guess the question is, once we have this advanced information, how do we know what's the best way to monitor these patients and also counsel them? So maybe I'll invite Dr. Piro for his comments as well.
Oh, it's a very great question. And every great question is actually difficult to find a comprehensive answer to that. But so educating doctors is something has to happen in the medical schools. Educating individuals about probabilities goes against human nature to a certain respect, because as humans we just kind of want certainties and we want a firm recommendation to do something. We are sort of not built to cope with the probabilistic nature of a lot of the genetic information has to offer us. The first step practical step in that direction would actually be to improve the quality of the recommendations that are based on genetic data, for example, and genetics actually have a role to play, and the field has to move forward and make the data more digestible. But the second step we can take in that direction is to further educate, as you're just mentioning, attending doctors to make a better information of that genetic information. We know so far that, for example, smoking is bad for you. A lot of doctors feel comfortable just recommending people stop smoking or change their diet with respect to exposure or risk to particular diseases. It might actually be a first step to educate doctors about the risk scores of how big is the risk factor associated with polygenic risk scores in their specialties. And it's something that can be put into perspective and can be digestible for many doctors. Essentially educating doctors about what the odds ratios are. What does it mean to have a bad heritability compared to being a little more robust in that field? So.
Okay, great. We have 3 more questions here. One of them is early cataract also genetic in origins? And I think he or she is asking because sometimes, doctor recommend early cut titration, right? But IOL also have a limited shelf life according to the manufacturers.
Well, I think cataract is definitely like genetic. There are already quite a few loci that have been associated with cataract development. And I would just argue that all our genetic studies on cataract's susceptibility are essentially like an age of cataract, like the study design. Essentially, like if we live to be like 200 years old, like every one of us will actually get related cataract. So what we call cataract cases are just like cases of early cataract, and we're just comparing them with people with delayed cataract in the population. However, the cataract studies are not as advanced as those for other eye diseases. It is very difficult to define what cataract is. You have to conduct ad hoc quantitative measurements in the population to come up with a sort of good quality genetic association study. So we don't have a good like understanding. We know like a few like genetic risk factors. We don't quite know like the true strength of that association and what form of cataract they're predisposed to. So that field is slightly lagging behind, but hopefully catching up in the next sort of like few years.
Okay, I think the next question is regarding the metabolomics and proteomics. Since do you think they are more addressable and treatable than the genetic disease marker, and therefore result for the other omics study like metabolomic proteomic will be more clinical translatable than the polygenic risk score? This is also something I would love to know.
No, we've done a lot of work on sort of metabolites together. Absolutely, I'm a huge believer in metabolites for many reasons. Not so much just for they're weak predictors of disease. For most eye disorders, they have been like weak predictors, but they have this huge potential when it comes to like developing new drugs. Metabolites are small molecules that somehow they are involved in that chain of mechanisms that go from the genetic risk at birth all the way to developing eye disease or like any disease symptoms like later in life. And they're immediately addressable. So we already know of certain metabolites that, for example, are strongly associated with glaucoma. And we are like in our different ways, we're actually working towards like using them for therapeutic purposes. Again, both Professor Chang here and myself, like sometimes alone or sometimes in collaboration, we've identified quite a few metabolites that are of particular interest in terms of controlling for like IOP measurements in the population, and those metabolites hold a great promise. We haven't done enough because primarily it's very difficult to actually quantify cataract in the population. We haven't done enough in terms of metabolites and cataract, but it holds a huge promise for the future as well.
Recently, I believe the UK Biobank also released the proteomic data, right? So it's also a very good resource to look into the question on the proteomics and the disease.
Potentially. I just started working on proteomics in the context of eye diseases. Proteomics is great for many diseases, but I'm not sure yet. And it might be like great for eye disease as well. It's a whole thing that whatever happens in the eyes will find some difficulty to actually just go to like the circulating blood. So unless we take so biopsies like straight from the eye or like an aqueous humor sort of like assays, we will never be sure at this stage whether proteomics promise is going to materialize in ophthalmology or not. It might, but we don't have enough data for that.
Yeah, good. So actually, so the last question is more technical questions. Doctor, she is asking, she used the GWAS data on 3 co-equivalent from your papers, your GWAS paper, and they basically she observed that there's a difference in the genetic correlation and Mendelian randomization. Basically, that means the genetic correlation is negative, but the Mendelian randomization turned out to be positive associated. So, in your opinion, what's the underlying causes? And the other question that for some GWAS open data summary statistics, right? There's no SE, and do you have any approach to generate this estimate, and we can allow people to do the Mendelian renovation analysis?
Right, I'll start from the very last very briefly. So if you know the Z-score and the population, like effective population size, you can actually back engineer. You can actually find a standardized beta and a standardized standard error for those estimates. So it's actually standard. Among many other sort of like sources, there is this paper from the GIANT Consortium, strangely advising people on how to conduct meta-analysis that has like very good formulas that can be used in sort of like going back from a z-score and a sample size to proper estimates of effect and standard errors of estimation. So I just recommend reading any of these papers because they're pretty simple and they'll take you somewhere. In terms of like, I'm not quite sure, like, I just got the spherical equivalent parts. I'm not quite sure what is the other, so what is the exposure and what is the outcome, if that's spherical equivalence or like no question. So I would have to give a general answer. So it may not be exactly what the person was asking for, but it's possible to have two different directions when it comes to observational correlation and Mendelian randomization. It's very common. So if you think, for example, in a healthy person, okay, if you take a lot of sugar, your glycemia is going to be correlated with high levels of insulin. Insulin will be released in response to your high blood sugar. But from that, you cannot infer that actually insulin increases glycemia or glycemia. So it is also like a matter of having the right directionality. It's very common to actually just conduct Mendelian randomization studies. And if you did that properly, you would actually see that the true direction is that, yes, sugar causes, like on the short term, increase the levels of insulin, but insulin primarily lowers the glycemia, not the other way around. So Mendelian randomization studies help you go past that short-termism that you can see in the observation studies.
Okay, great. Actually, the one who is asking a question, Dr. Xu, happened to be my fellow. So actually, we can discuss more detail offline after this.
Absolutely.
Okay. I think time is up. So I mean, we have to finish this webinar soon. So again, we thank Associate Professor Pilo for his wonderful talk. And thank you all of you for joining us in this webinar. Thank you very much.